Hello, everyone. My name is Cheryl Carlson, and I am the Program Development Educator for Geriatric Services. There are many reasons why an elderly person could be confused or disoriented, have losses in their ability to do their ADLs, have changes in behaviors, and have language difficulties. Today, we are going to discuss one of the reasons of confusion, delirium. There are several data methods to identify and provide information and statistics about the geriatric population, such as the Canadian Institute of Health Information, which is CIHI, and Minimum Data Set, which is MDS. MDS has several algorithms built in the program, one of which triggers delirium. MDS also provides information on resident use of antipsychotics. We know antipsychotic medications are overused and can cause lots of problems that could greatly affect the quality of life in the geriatric population through their side effects, drug interactions, and contribute to geriatric syndromes, for example, falls or increase in frailty. One of the problems is that overuse of antipsychotics can contribute to delirium. As you can see from this slide, Saskatchewan has the second highest percentage in long-term care facilities in Canada. Geriatric Services created an order set and algorithm with the goal of increasing awareness about delirium, as well as to guide physicians, nurse practitioners, nurses, and other interdisciplinary team with the detection, assessment, interventions, both non-pharmacological and pharmacological, and treatment of delirium. The target population is the geriatric population in both acute and long-term care. The education will include nursing staff from both long-term care and acute. I recognize procedures and routines may differ between acute and long-term care. However, the content and information applies to the geriatric population, whether you work in acute care or long-term care. At this time, I would like to acknowledge Dr. Durrani, Kathy Billett, Jen Troy from Geriatric Services, Dr. Bazaran from Saskatoon, Dr. Bimboy, as well as Dr. Carmen Johnson, Michelle Dagelman, Bob Parker, Jillian Norlander, Taryn Lorenz from Acute Care, among many others, for all their hard work and commitment. Jen and I have already provided education last fall to both the regulated and non-regulated nursing staff during their long-term care nursing days, as well as the long-term care clinical meeting in March, and will continue to do so with the support of the long-term care CNE team. Our pharmacist, Jen, has already provided education to the pharmacists at both RGH and Pasco Hospital via telehealth. Dr. Durrani and Kathy, who's our transition lead, will provide information to the physicians. Future plans include development of education packages, web access for nursing staff who were not able to attend the education days in acute care that were held at the end of May and beginning of June. I have already provided this education during those education days. We are going to work on e-quizzes, and then there will be the determination as to how often the reviews will need to be reviewed. So at this time, I'd like to introduce the documents. In lieu of the PowerPoint, these documents will be provided. So there is the PPO, which is called the Suspected Delirium in the Elderly, and it should be available in the PPO site in early July. The accompanying algorithm, which is called the Delirium algorithm in the elderly, it is already available on the PPO site, and you can pull that off. So the other two documents that I will be referring to is the Confusion Assessment Method, which is called the CAM, as well as the 3D document. Those two documents are available in the Long-Term Care Department site in the Delirium section. And we will also be building more resources in the future, so I encourage you to check our long-term care site regularly. So we're just going to go back and look at this slide here where it has the percentage of long-term care residents with symptoms of delirium. What this means to folks who are working in long-term care is that it really enforces the importance of detecting and assessing for delirium, providing appropriate interventions and treatment. For acute care, it could mean that the client may have a past history of delirium or be in a delirium already prior to the admission to acute care. So the objectives for this presentation are to establish the recognition of delirium, discuss risk factors and causes of delirium, discuss the impact on functional status, quality of life for our residents, the assessment tools, look at goals of treatment and what the treatment options are. So at this time, I would like you just to consider whether or not that you have been exposed to a delirium, or perhaps you've been in a delirium yourself. Questions to think about is, how did you know it was a delirium, and what were some of the symptoms? Before we really get talking about delirium, I would just like to discuss a few special considerations in the elderly that are appropriate at this time. So assessment is complicated by age-related changes, multiple comorbidities, and the atypical presentations. Age-related changes can alter disease presentation, the response to treatment, and outcomes. And we don't have the capacity to discuss all the age-related changes, but the following are a few examples that can contribute or complicate your assessment. There are changes in the liver and kidney function, which will affect the body's ability to metabolize and excrete medications. There's a decreased thirst sensation, which can put an elderly at high risk for dehydration. So instead of asking if they are thirsty, please just offer fluids and assist as necessary. There are vision changes such as increased sensitivity to glare, loss of accommodation, or ability to focus clearly and quickly on objects at various distances. There's diminished acuity, delayed dark and light adaptation, reduced visual field, as well as diminished depth perception. And what that means is that the elderly need more time to process what they are seeing. There could be changes to thermoregulation, which is the body's response to infections. It may not present with a high fever, so it's important to know the baseline temperature. So, for example, if their baseline is 35.7, then potentially a temperature of 37.2 might indicate a fever. Illness in the elderly is complicated by multiple medical problems and the physical changes that naturally occur as a result of aging. Anytime there's a decline in functioning or a decrease in appetite or change in behavior, that may be the first sign that something is changing or there's an approaching health problem. When we look at atypical presentations, they can present as a vague presentation. So, for example, there's those non-specific symptoms such as confusion, falling, incontinence, self-neglect, apathy, anorexia, fatigue. Another presentation could be altered presentation. This can present a confusing picture because the classic symptoms that we see in a younger adult may not be present in the elderly, especially the more frail and debilitated the elderly is. So, for example, an example of an atypical symptom in an elderly person is, let's talk about a heart attack. They may present with a delirium rather than the typical or classical presentations of chest pain or shortness of breath. So families or staff's observation that mom is not herself today should not be taken lightly. Non-presentation, which is those hidden kind of presentations, might be an example of a depression or poor nutrition, and you might hear a family member say or a staff member say, oh, they've always been that way. So to summarize the following, and we'll use vision as an example, we know age-related changes in vision include changes to acuity, that depth perception, sensitivity to light and glare, decreased response time to understanding what they're seeing. And then there's a disease process that interferes with the vision. So, for example, cataracts or glaucoma. They also have a diagnosis of a dementia. And we know that there are changes in vision with dementia. For example, the loss of the ability to track fast-moving objects, reduced peripheral vision, and color contrast. And they've had an increase in falls and functional status, again, those vague symptoms. Plus, they're receiving medications that can dry out the eyes and cause blurred vision. And what can happen is that it can really make the assessment quite complex. So this can result in misdiagnosis, which delays treatment, increases the risk of unnecessary medications, investigations, and whatnot. So what I'm really trying to say is that sometimes the insignificant can become significant. Other special considerations to consider is that it's easy to make assumptions, especially when all we see are behaviors. And really what happens is that some of the behaviors could be the symptoms. The elderly are highly vulnerable to the effects of medications. We know that folks who are 70 years and older could be 3 times higher at risk for admission to hospital as a result of side effects of medication as compared to younger populations. And lastly, the risks of side effects increase with age and the number of medications. So when we look at delirium, it can be described as sudden confusion, acute confusion state, cognitive impairment, when actually it is a clinical diagnosis. The word confusion is a generalized term that doesn't emphasize the seriousness of the condition. Delirium was recognized 2,500 years ago. Again, it is a clinical diagnosis that is often unrecognized in the detection, assessment, and interventions and treatment. It needs to be treated as a medical emergency until proven otherwise. What we see is a disorder of attention and cognition, so there's changes in the attention, which we will be discussing in the next few slides. And what happens is that it creates a complex interrelationship between vulnerable elderly with risk factors and then exposure to the contributing factors. Delirium has long-term consequences if the symptoms persist, and some of those consequences include decrease in function, which would be the mobility, independence, you may say an increase in continence, and the inability to provide or participate in their ADLs. It could also lead to permanent cognitive impairment and or dementia. There's a spectrum of severity, and that varies in degrees of the severity. And so, for example, some of us, we can use the analogy that some of us get a cold. It might be from the same virus, but I become much sicker than you do. And it's all about looking at the risk factors and the health of your patient or resident. The duration of delirium varies, again, depending on risk factors of the resident, the causes for the delirium, when it was detected, and what the response to treatment was. Persistent delirium can range from 6 months up to a year or longer. And what happens, again, is that it complicates the care in regards to the detection, assessment, the interventions, and treatment of the delirium. In acute care settings with delirium, 15% of elderly people admitted have a delirium. 56% will develop a delirium once admitted, and 30 to 40% become delirious after hip surgery. With residential care settings or long-term care, 40 to 60% of residents will develop a delirium at some point. And so I encourage you to think about the residents who are admitted from hospital into long-term care and what it means. As we know, almost 60% of residents that are admitted to long-term care for acute care have developed a delirium. And so what does that mean for us? Potentially some of our residents that are admitted from acute may already be in a delirium, and vice versa for acute care. And what, again, the concern is that there may be inappropriately have a diagnosis of dementia when in fact it may be a delirium that has gone under-recognized. So in spite of these numbers, it is under-recognized. In 2000 and 2001, there were some studies made that recognized that 55 to 70% overall delirium was missed. And if we fast track to 2015, we're still at a fairly high number at 60% overall of delirium being missed. The leading cause of underdiagnosed is the neglecting the baseline mental status. You may have to dig deeper when you're looking at baseline, especially if your resident is admitted into long-term care from the hospital but was living in the community previous to admission, or if the client was recently in the hospital and now being admitted again. Baseline will usually be harder to obtain in acute care rather than long-term care. Other causes for underdiagnosis is confusion, and cognitive changes are accepted as part of aging. And again, failure for staff to take the diagnosis and looking at confusion seriously. Other causes are delirium can be superimposed on a dementia, the atypical presentations of a delirium, so a young, healthy adult versus the elderly. So again, for example, in a young, healthy adult needs a series of noxious insults or events or causes to trigger delirium, whereas in the elderly who are vulnerable may have dementia or have multiple comorbid conditions, something as benign as a dose of a sedative or hypnotic drug could trigger a delirium. And unfortunately, what happens is that it delays appropriate treatment and care. It is important to remember the brain is an organ. And so when we look at delirium, really what delirium is acute brain failure. So we can compare it to failure of other organs. For example, acute heart failure. Symptoms we may see are shortness of breath, anxiety, chest congestion, changes in vital signs, edema, etc. In a delirium, which is acute brain failure, the symptoms are acute onset with fluctuating mental status, problems with inattention, disorganized thinking, altered level of consciousness. And just like there are many conditions that could precipitate heart failure, there could be many causes that could precipitate a delirium. It is multifactorial in nature. When you look at this slide, the bolded print are the key features of a delirium, and we will be discussing further in the next few slides the meaning of this. There are 4 types of delirium: terminal delirium, hyperactive, hypoactive, and mixed. For the purposes of this presentation, we will only be looking at the hyperactive, hypoactive, and mixed delirium. Terminal delirium is irreversible and often occurs days before dying. When we look at hyperactive delirium, what it is an increase in motor activity. Symptoms that you are going to see are restlessness. You could see constant moving in a wheelchair, pacing, moving furniture, yelling out, disruptive vocalizations that are repetitive, agitation. There could be resistive to care. So, for example, hitting, grabbing, spitting. These folks are hyper alert. They're oversensitive to noise. They may startle easily. They're fidgety, often may be picking at clothes or IV lines or restraints. They often are in irritable mood. You could see paranoia as well as hallucinations. Hypoactive delirium, which is a decrease in motor activity, is more common in the elderly. It's least likely detected with higher rates of complications and mortality. And the symptoms that you are going to see there are slow to respond, their speech is slow, there's lack of facial expression, there could be increased sleeping. Mixed delirium is just what it sounds. It's a combination of both hyperactive and hypoactive, and that's where it can create a confusing picture for us because there often will be a fluctuation followed by periods of no fluctuation at all. And non-pharmacological intervention should always be the first line of intervention. The pharmacological interventions, certainly we would need to address distress. And when I talk about pharmacological interventions, I certainly don't mean if your resident or client has got an infection that we wouldn't give them an antibiotic. We certainly would try and treat what is treatable. When we look at pharmacological interventions, there's more so treatment with antipsychotics and the benzodiazepines. And again, I just want to remind you that the fluctuation in symptoms is a key feature of a delirium. And again, delirium is often missed due to the fluctuation of those symptoms. So what are the consequences of delirium? Well, we know that there could be a functional decline, which would include loss of independence, decreased ability to participate in their own care. They're more likely to develop pressure sores, falls, adverse effects to medications, immobility. They could have nutritional issues, develop a dehydration, as well as infections. Physical recovery, we know, can take up to and include in greater than 30 days. Cognitive recovery is much longer. We could see a cognitive decline, and unfortunately, it could be permanent. Delirium causes significant distress to residents, especially when they're very, very confused. Nothing is making sense. It could create a lot of fear, as well as there's an impact on the family and relationships. It's very difficult to look after somebody who's in a delirium. And then, of course, like I've mentioned before, the worsening of pre-existing dementia. I just want to mention, along with the cognitive decline, that long-term cognitive decline with risks of some residents never returning to their baseline cognitive function. In other words, like I said, it may be permanent. If not treated appropriately and timely, cognitive impairment is over 50% in surgical patients. And again, the cognitive recovery from a delirium is much longer. It could even be up to a year, especially after surgery. Other consequences of the delirium is that increases hospital admissions with increased hospital stays. So hospital admission from community to acute, long-term care to acute. There's a financial cost to the system as well as higher staff utilization. It is very complicated and can take a lot of time to look after somebody who is in a full-blown delirium. Much easier to have interventions to prevent a delirium from occurring in the first place. Again, we talked about the higher rates of readmission. There's increased risk from post-operative complications, increased risk of admission into long-term care, and unfortunately, increased risk of mortality. Even after the increased risk of mortality can be as high as even after 1 year of discharge from hospital. There are diagnoses that mimic delirium. So, for example, dementia, depression, psychosis, and then a delirium superimposed with a dementia. And what I mean by that is that I could have a dementia, say, for example, an Alzheimer's dementia, and have some risk factors that would increase the risk of me developing a delirium. And in fact, I've developed a delirium. So I have a dementia, and now I have a delirium on top of that. What's really important is to differentiate with using cognitive screening and observations of those key features. And I just want to point out that delirium is much easier to detect with someone who's cognitively intact versus someone who's not cognitively intact. So I'm going to very briefly just discuss the differences between a delirium and a dementia. One of your handouts that's called the 3Ds, or Recognizing Delirium, Depression, and Dementia, certainly provides you with some more information in regards to what the differences are. So with the delirium, one of the key features of a delirium is that sudden onset. With the dementia, there's a slow and gradual deterioration. So in other words, we don't just catch a dementia. One of the key features, again, with the delirium is difficulty with attention, whereas with the dementia, we see problems with attention later on during the disease progress. Delirium is reversible with treatment, whereas unfortunately with the dementias, it is irreversible. At best, we can treat the symptoms. In a delirium, there's fluctuation, as you can see, in cognition, thinking, perceptions, and alertness. There could be emotional outbursts, anger, crying, fearful, and again, that could be fluctuating back and forth. Sleep is generally disrupted. There's no set patterns. It could differ from night to day and day to night. And hallucinations, and often when we see hallucinations in a delirium, they can be very frightening. Whereas with a dementia, we do see cognitive decline with changes in memory, language, recognition, and not only recognition of self and family members, but recognition of tools and what they're used for, purposeful changes in purposeful movement, in their judgment and insight. Generally, we see low mood in the morning. Apathy is common, and again, it can be confused with depression. And sleep patterns could be disrupted, but they would be individual pattern changes. The other thing that I do want to mention in regards to delirium and dementia, and what they do have in common, is that their ability to cope with stress, or that stress threshold, decreases. So, for example, if somebody is sick, having some pain, it can certainly take a lot of energy and cognitive resources to be able to cope with the condition. With the dementia, again, it can take a lot of cognitive reserve because they're trying to figure out what is going on in a world that is slowly and steadily making no sense at all. So who's at risk of developing a delirium? If you look at your algorithm, you'll see on the left-hand side that this information is already there. So anyone that's greater than 75 years and older, and we know that the 75-year-old group is the highest growing age group. If there's a previous history of delirium, and like I mentioned before, they're all the more vulnerable of developing a delirium. Diagnosis of neurocognitive disorders, again, there's that lack of cognitive reserve. And so with someone who has a cognitive disorder, again, I had mentioned in the previous slide that it takes a lot of energy to navigate the world, but other things that would cause some difficulties for them as they're navigating the world is the environmental stresses such as noise, relocation, staffing levels, medical treatments, and whatnot. Again, multiple comorbid conditions, acute and or exacerbation of a chronic disease that can certainly cause complications. We talked already about fever and the elderly's reaction to fever and infections. Certainly anyone who's had recent surgery, falls, fractures increases the risk for a delirium. Pain as well, like I mentioned before, it can take a lot of energy to try and cope with the pain. Other things that I do want to mention here very quickly is restraints. Folks who are on 5 medications and greater, as well as the psychoactive medications, are 4.5 times a greater risk of developing a delirium. So when I talk about the psychoactive medications, those are the medications that are antipsychotics, antidepressants, benzodiazepines, cholinesterase inhibitor medications, as well as sedatives. Certainly nutritional sensory deficits, and I've already discussed that, alcohol abuse, insomnia, and depression just increase that risk. Generally speaking, there are multifactorial conditions or causes that can contribute to a delirium. Sometimes it is that simple and it's one cause, but certainly research shows that it's generally the multifactorial causes. I Watch Death is an acronym that is used to explain the potential causes of a delirium. Folks in long-term care who are PIECES trained certainly can refer to their yellow PIECES job aid as it's included on that job aid. So I, standing for infection, so you've got UTIs, pneumonia, encephalitis. W, meaning withdrawal, and that would be withdrawal from alcohol, the benzodiazepines, sedatives. A, acute metabolic, that we would see as electrolyte disturbances. So keep in mind when you have residents who are who have had diarrhea, perhaps emesis. In long-term care, if you've had someone, if you've been in an outbreak from a viral infection, that they're at much higher risk of developing a delirium. Again, looking at highs, hypernatremia, hyponatremia. T, standing for toxins, could be your opioids and anticholinergic drugs. CNS is the CNS, or C standing for CNS pathology, stroke, seizures, hemorrhage, infection, and again, tumors. Hypoxia could be a result from anemia, lung, heart failure, hypotension, and whatnot. And so death, deficiencies, B12, especially from alcohol abuse, endocrine problems with thyroid, hypo or hyperglycemia, adrenal problems. And you can see shock, hypertensive encephalopathy, as well as trauma from head injury, post-operative, and then again hypo and hyperthermia. I just want to take a minute just to talk again about dehydration. Some statistics indicate that up to 50% or there's a 50% mortality rate for untreated dehydration in the elderly. As we discussed at the beginning of the presentation, there are age-related changes in the decreased ability to identify thirst and a decrease in total body water. Dehydration can be a cause of physical and emotional illnesses. And for you folks, particularly in acute care, be aware of the potential for dehydration with medical procedures, especially those that have NPO and immobility. Clinical signs of dehydration may not be evident until the dehydration is advanced. So, for example, the skin turgor at the sternum is an unreliable sign due to the loss of subcutaneous tissue. It's better to look at that if there's dry mucous membranes, furrows or deep furrows in the tongue, incoherent speech. What I really want to stress here is that we want treatment to be acute, so treating the problem and then ongoing interventions to decrease the risk of the delirium from happening. And so we have vulnerable elderly with risk factors, contributing factors or insults to the body that build on each other, which results into a cascading iatrogenetic effect. The higher the number of risk factors or predisposing factors, the less the number of precipitating factors for the development of the delirium. And you will have an incomplete plan of care if you just treat the one cause. There are several drugs that are believed to cause or prolong delirium. I'm just going to identify some of the classifications. So analgesics, which would include opioids or NSAIDs, antibiotics, antivirals, anticholinergic medications, seizure medications, antidepressants, cardiovascular and hypertensives, the steroids, gastrointestinal agents, hypnotics, muscle relaxants, and so forth. So really, the goals of treatment are to try to prevent the risk of delirium from developing in the first place. We know that 30 to 40% of delirium is preventable, and prevention is much easier to treat than someone who is in a full-blown delirium. What we need to do is use a non-pharmacological approach is best practice. We want to reserve treatment with medications for the most severe symptoms and or behaviors. We need to treat the underlying causes. We want to prevent complications. So, for example, we want to prevent aspiration. So those nursing interventions that we do already is to be aware of our feeding technique. Is the bed in high position? Are we using a small spoon, etc.? So other complications, like I said, we need to prevent our dehydration, problems with nutrition, ulcers, clots, pneumonia, and immobility. The goal is to try to improve and resume functional abilities and their cognition, and certainly we want to promote health, dignity, and quality of life for your resident or patient. So baseline assessment is key to having an accurate diagnosis. Certainly when you are trying to glean information from family members and from other staff members, it's really important to know what they were like and how they were functioning prior to admission to the hospital or prior to, if they were admitted to long-term care from the hospital. So, for example, when you're obtaining a baseline, we need to clarify if the cognitive changes, inability to concentrate, fluctuations in presenting symptoms are new, or if so, when did the change emerge, or if it already existed, is it worse or different, and when did those changes occur? We need to be very clear that the baseline may They may have to go back to 6 months or so because potentially the acuteness may have been missed. When you're talking with your family members, you may have to rephrase questions a bit. So asking if there's been sudden changes in ability with the ADLs or IADLs. Have they had trouble paying attention, can't stay on topic, or finish a sentence? Just overall trouble understanding conversations and following conversations. Are they more forgetful than usual? Is there disorientation to time, place, or person? Are they having trouble recognizing people, and that would include family members? Are there sudden changes in the mood? Are they more worried, angry, fearful, or sad? Are they seeing or hearing things? Is it harder to wake up, or if they can wake up, stay awake? Are they quieter than usual or more restless than usual? When you are looking at baseline and doing your baseline assessment, it's also important to consider their past and recent health history. So we're going to now look at the algorithm as well as the PPO and the CAM. But before we really get started, I want to discuss the CAM because the CAM is really embedded in both the PPO as well as the algorithm. So the CAM is a tool that is used to determine if the change or behaviors in the patient's presentation is suggestive of a delirium. It is offered in 19 different languages. It helps to determine the presence. There is a CAM that's called a CAM-S, and that CAM is a little bit longer, but it will help you to determine the severity of a potential delirium. The information is obtained by observation from the staff, from family's observation, in the progress notes, as well as on the DOS or the direct observation system, which is a behavior mapping tool. This is where it's really important when you're describing, reporting, and documenting to be as objective as you possibly can be. We need to really be aware of our personal values and not make assumptions in regards to behaviors or the symptoms that we're seeing as to suggesting that they're purposeful or aggressive. One of the key questions when you're using the confusion assessment method is to consider what has changed. So in other words, what am I seeing and what am I hearing? So now you have the CAM in front of you. I just want to talk very quickly about the CAM. So you'll notice that there are 4 questions or 4 domains that you want to consider when you're looking at a CAM. The first 2, which is in acute onset and fluctuating course, and then the next one is inattention. When you're looking at question number 1, you'll notice that there are 2 parts to this question. Generally speaking, when you're assessing for question number 1 and wanting to answer it, you usually can't answer this question through your observation. You're going to have to, this is where you're going to have to go back, talk with staff, talk with family members to try and get a good sense of what their baseline assessment is like. So 1A, you're asking yourself, is there evidence of acute change in mental status from the person's baseline? And again, you're looking at orientation, cognition, any changes in behavior or changes in mood. The second part of this question, number B, is did the abnormal behavior fluctuate during the day? That is, did it tend to come and go or increase and decrease in severity? And those changes may occur hour to hour, may occur shift to shift, and you might even see some changes in the days. So we've looked at question number 1, and now we're going to look at question number 2, inattention. So inattention is defined as reduced ability to maintain attention to external stimuli and to appropriately shift that attention to new external stimuli. So the patient seems unaware or out of touch with their environment. For example, they may look dazed, they might be fixated, or have darting attention. Questions that you want to ask yourself are, did the patient have difficulty focusing attention? For example, being easily distractible or having difficulty keeping track of what was being said. You may see patients have a blank look on their face, almost like they're not registering. They might be asking questions frequently because their attention wanders. And again, If they are asking questions repeatedly, it's always important to consider whether or not they have a hearing deficit, and if they do have a hearing aid, to make sure that the hearing aid is in, the batteries are in, and that the batteries are working. They may have difficulty making eye contact or any prolonged eye contact. Their focus seems to be darting around the room. They may do other things like stare and stand by a doorway, just staring into space, and then looking into another resident's room. Again, they might look dazed, staring at the TV when you ask them a question. They look at you momentarily but do not answer, and then continue to stare at the TV. And you will see these kind of symptoms during personal care. So, for example, eating, feeding, mobility, inability to follow instructions. You might see inattention when you're trying to give medications. Other things that you can consider is that your patient may have been able to follow 3 or 4 word commands, but now you really have to simplify it to 2 or 3 simple word commands. So when you're looking at question 1 and 2, you need to answer 1A, 1B, and inattention. And in order for a delirium to be suggestive, we would have had a yes to all 3 of those components. Now let's look at question number 3 and question number 4. This is where disorganized thinking and altered level of consciousness, you don't need both of these domains. It could be a either or. So disorganized thinking is concerning, was the person's thinking disorganized or incoherent, such as rambling or irrelevant conversation. They may be unclear or have illogical flow of ideas, or be unpredictable, switching from subject to subject. And of course, the only way that you would be able to assess for this is that if your patient or your resident could talk, or if they can write. Number 4, which is altered level of consciousness, you would consider whether or not your patient is hyper alert or vigilant. Are they drowsy, but they're easily aroused? Are they in a bit of a stupor? In other words, they're very difficult to arouse. You'll have to use a louder voice. You may have to shake your patient a little bit, and then they may very quickly fall back to sleep. And of course, a coma, you wouldn't be able to arouse. Again, I want to remind you that if somebody is in that hyper alert form, that they are going to startle very easily. So I really encourage you, and it's really important to make sure that you differentiate between a lethargy and a stupor. Inattention and level of consciousness should be assessed separately. A patient who's lethargic or stuporous may still have intact attention during the periods of arousal or when they're a little bit more clear. So now that we're done talking about the CAM, let's now take the algorithm. And the algorithm, like I say, is called the delirium algorithm in the elderly. You'll notice that in the middle of this document, it refers to you, it asks you to assess for delirium using the confusion assessment method. So the document that we just talked about is the document that you would complete. You'll notice right under where it says complete CAM that it gives you the order number of this document. There are 3 areas that you would be looking at. If the CAM is positive, we need to assess for the cause. If the CAM screen is positive related to alcohol withdrawal, to use the PP 535. If the CAM screen's negative for delirium, but your client still has a history of dementia, you'll want to refer to the guidelines for behavioral expressions in neurocognitive impairment. So when you look at the left side of this paper, you'll see there's a discussion and a reminder in regards to risk factors of which residents or patients are at higher risk of developing a delirium. On your right-hand side, you'll see the causes of a delirium. And again, there's the iWatch death algorithm. Halfway through the page now, it talks about areas where you need to be starting to do an assessment. So you would be looking at pain, and again, looking at and considering regular pain assessment and monitoring using a validated assessment tool every shift. our department, and for folks who have a dementia, the pain assessment tool that we use is called the PACSLAC2, which can be retrieved in our long-term care site. The only thing that I really want to say about a PACSLAC, if you're not familiar with it, first of all, the instructions are included with the PACSLAC. And basically what the PACSLAC is a checklist. You're looking at 6 different domains that could potentially represent or indicate that somebody who has difficulty communicating might be in pain. And we know that anyone who's in pain, it can really affect their ability to concentrate. So when you're looking at the PACSLAC, you want to be doing that critical thinking, looking at the diagnosis. Is there a diagnosis that supports a potential pain? Sometimes pain behaviors in someone who is having difficulty communicate or in a dementia may look aggressive, it might look resistive, or the behaviors might be looking as challenging. So all you're doing basically is you are recording, and there's room for it on this document, the activity during observation. You want to do at least 2 PACSLACs per day during some type of movement. So, for example, repositioning, transferring from bed to chair to bed, onto the toilet. You want to date the observation as well as the time. And really all you're doing is checking if you are seeing some of the descriptors present. So, for example, what's their facial expression like? Is there grimacing? Is there a tighter face? Is there increased eye movement and whatnot? So my recommendation in my experience has been is that if you take somebody in with you and they can actually watch you as you're providing care and have that second staff just tick off if there's any of the symptoms on the PACSLAC. There's no magic number to indicate pain. What you're looking for is either an increase or a decrease in the symptoms or the numbers. You want to do it, like I said, at least for 3 days during some type of a movement. So going back to the assessment and interventions, and I really want to reiterate at this time, is that this algorithm is designed and is useful to prevent a delirium, much easier to prevent a delirium than treat a delirium, as well as you can use it if somebody is in a full-blown delirium. Excuse me. So I'm not going to go through it step by step, but you can see that we need to do an assessment on pain, need to do an assessment on their nutrition. Again, remembering that in the elderly, there is generally a decrease in that thirst sensation or ability to identify thirst. You want to look at retention, their bowel movements, as well as avoid any unnecessary catheterizations. Restraints, we know restraints can prolong delirium. We only want to use restraint if the patient is a danger to self or others. We know restraints in itself can cause falls, confusion, anxiety, incontinence, and overall decrease in their functions. When you look on page 2, there's a room to assess for infection or illness, looking at immobility. And again, we want to be able to, or at least attempt to mobilize at least 3 times a day unless contraindicated as per their TLR assessment. Sleep is really important. We want to assess for that altered sleep and wake cycle, and we can do that by using the direct observation system or the DOS. And again, on this document, you'll see where you can find that form. It is form number 1422. That form also is available in the long-term care section. When you're looking at sleep, we know that sleep can be very disrupted in a delirium. We want to avoid waking up and disturbing for vital signs, labs, weights, etc., if at all possible. Increase exposure to light during waking hours, which helps with that natural rhythm. Again, looking at sensory, making sure eyeglasses there, and hearing aids. I want to talk very briefly about the mental status. We're looking for any sudden changes, emotional trauma, hallucinations, delusions, and this is where our interventions and our interactions are really important. We want to address the client by their name, and that assists in getting their attention, and we know already that they've got it decreased in attention. We need to be careful how we communicate, allowing time for your patient or resident to process and respond to the information. We need to repeat instructions if necessary, one task at a time. We want frequent orientation to where they are, who you are, what is happening, what the date is. Acknowledge and validate fears, especially if it's related to hallucinations or delusions. They could be feeling quite fearful. And again, anything that we can do to attempt to normalize activities by using calendar, clock, whiteboards, open the curtains, and making sure that the care plan addresses the fluctuations in symptoms. Medications, we've talked a lot about medications already. Again, just reiterating that we want to start low and go slow, and then assess for psychotropic medication response and report the side effects, for example, those increase in anxiety, agitation, any Parkinson-like symptoms, possible decrease in blood pressure, and whatnot. And again, also looking at the environment, taking into consideration noise levels, lighting, and their overall exposure to daylight. Page 3 of this document talks about monitoring, talks about some of the management of side effects, as well as prescribing tips. So the next thing I want to talk about is the actual PPO, and hopefully at the time that you're hearing this, that you will have access to the actual document. So it's 2 pages, double-sided. The first page really speaks about the non-pharmacological interventions that you would have the physician. We would be using this if there's a suspected delirium, whether it's a hypoactive, hyperactive, or a mixed delirium. And again, provides you instructions to use the CAM. And this PPO, it's reiterated again, is not to be used for alcohol withdrawal, if that's what you're thinking that the delirium is from. Again, referring you to the PPO number 535 for alcohol withdrawal. So you'll see each box has got instructions, if you will, so there's investigations or tests that the physician might want to order, consults and referrals, and you'll notice the second last consult is for geriatric services if the behaviors are not resolved. And I'll let you know at the end of this presentation how you can access geriatric services. Then there's nutrition consideration, mobility, and then the observation requirement. Turn the page over now to the second page of this document. First-line management of agitation or patient distress in delirium is the non-pharmacological approach. And again, this document refers you to the algorithm for further direction. If you do have to use medication, we want to consider medications if there's a risk to self or others and no improvement with the non-pharmacological interventions. It again guides you a little bit more and suggests that you use only one antipsychotic at a time, using the PO route first, if at all possible. All medications used in the treatment of delirium should be reassessed at least weekly and then discontinued when the delirium clears. Again, we want to avoid the use of the benzodiazepines. And if the patient is already prescribed an antipsychotic, what we would like to do is optimize the current dose first. So the last little part of this PPO, it gives you options as to which antipsychotic that you can use. Certainly, you would not use every single antipsychotic. We know that Haldol has the best evidence. However, you could use Seroquel as well as or risperidone or olanzapine. So when you look at here, you'll see that day 1 and day 2 are kind of the loading doses, and then as we start getting into day 2, day 3, day 4, day 5, we're tapering off. So you have the option of using Haldol, really important, and you may have to point this out to the physician. If there are patients that have Parkinsonian-type symptoms or a diagnosis of Lewy body dementia, it is recommended that you use Seroquel above the other antipsychotics. Again, there are alternate agents for patients without the Parkinsonian symptoms, so risperidone or olanzapine. And that's basically a description of your algorithm and the PPO. So moving on, there can be supporting tools that can help with the diagnosis, the interventions, as well as the evaluation of treatment. So I did briefly talk about the direct observation tool, which is referred to as the DOS. The DOS can help to establish whether or not, sort of help us to establish the sleeping patterns, kind of when behaviors or symptoms are occurring, as well as we can use it as a evaluation tool to see whether or not the interventions that we're using are actually indeed helping. The mini-cog or quick screening tool, long-term care nurses may be more familiar with this tool than acute care, but it can help as well, help sort of determine whether there's problems with inattention if you're having difficulty assessing that. Mini mental exam will help as well with cognition. I do want to say that the mini mental state exam, it may be necessary to redo the mini mental once the delirium is resolved, because in a lot of cases the mini mental could be fairly low. The GDS and the Cornell scale for depression will help rule out or help support your data in regards to whether or not you think that there's a depression as well. And we've already talked about iWatch Death and that acronym. Really important to get the tools. They can be obtained through the long-term care department under forms. Really important to use the most current tools. So now we're going to just switch a little bit and talk about medication treatment options. I just really want to point out that I'm not a pharmacist, so the information that is provided here was provided from Jen, who is our pharmacist. There's a lack of high-quality evidence to support drug treatment of delirium. Underlying causes, which could be infection, medications, electrolyte disturbances, should be addressed first. Antipsychotics should only be used for those who are severely agitated, hallucinating, or in severe distress. Haldol and the atypical antipsychotics, such as olanzapine, Seroquel, risperidone, appear equally safe and effective. Medication treatment options. Use the lowest dose and most effective dose and then titrate for symptoms. Risk of adverse reactions is relatively low with the short-term use of antipsychotics in patients treated for delirium when close monitoring and dose titration are used. Potential harms. Monitoring side effects are very important. Of course, our resident is already vulnerable. We need to be aware of the side effects and provide appropriate nursing interventions. For example, if the medication is causing sedation, we need to monitor fluid and nutrition intake, mobility, etc. So potential harms could include increased weight, hyperlipidemia, and hyperglycemia, sedation, lethargy, falls, postural hypotension, confusion, agitation, delirium, akathisia or restlessness, and with restlessness, there is increased risk of being physically and chemically restrained as well. Extrapyramidal effects, or your EPS symptoms, are drooling, rigidity, stiffness, akinesia. So rigidity could be, and stiffness could be misinterpreted as resistive to care. So I often encourage nurses when they're getting report and getting information to have staff show them if they're saying that the resident is resistive to care, what exactly that they're doing. Akinesia is opposite of akathisia, where there's overall slowness of movement. Tardive dyskinesia, which is involuntary, it's repetitive body movements, so you could see movements of the tongue, face, eyes, increased blinking, and whatnot. Acute urinary retention, as well as infections that could include either respiratory or urinary. Also concern are risk of stroke. We know that there's a high risk with higher doses, older age, with the diagnosis of dementia, particularly and especially vascular dementia, as well as comorbid atrial fibrillation. There is increased risk of mortality. This is controversial. We do know again that it's increased risk with increased dose. Always use the lowest effective dose and then stopping that treatment associated with that reduction in mortality. Haldol, the most common effects or concerns with Haldol are altered cardiac conduction, anticholinergic effects such as dry mouth, constipation, urinary retention, blurred vision, confusion, and a delirium, CNS depression, esophageal dysmobility, which could result in aspiration, and of course extrapyramidal symptoms or your EPS symptoms. Orthostatic hypotension with Haldol can cause falls. Quetiapine. Of the atypical antipsychotics, quetiapine is the best option for those with Parkinson's or Lewy body dementia. Common side effects include sedation, dizziness, postural hypotension, headache, anticholinergic effects, QT prolongation. Risperidol, the most common side effects include hypotension, sedation, akathisia or that increased movement, EPS symptoms, especially when the doses are greater than 2 to 4 milligrams a day, tardive dyskinesia, and then again the anticholinergic effects. Olanzapine is common side effects for olanzapine include sedation, again, anticholinergic effects, the cognitive adverse effects, so increased confusion. There could be rapid and significant weight gain and problems with hyperglycemia. Benzodiazepines such as lorazepam should be limited to specific instances, for example, delirium associated with alcohol withdrawal. Side effects include sedation, dizziness, which puts increased risk for falls, poor oral intake, and disorientation. Benzodiazepines can contribute to disinhibition, which in turn increases the risk for antipsychotics. When we're looking at discontinuing drug treatment, medications to treat delirium are typically needed for 1 week or less. Want to consider stopping drug treatment, tapering if necessary, once the symptoms are controlled, and evaluate the need for continuing treatment on a daily basis. Data shows that 50% of patients who start on an antipsychotic medication for delirium during an ICU stay continue on the drug after discharge from ICU, and most are subsequently continued on the drug after discharge from hospital. Continuing antipsychotics unnecessarily can increase the risk of drug side effects. Prevention and treatment of delirium is a multi-team approach. Communication and documentation between long-term care and acute care at time of admission and discharge is really important. And so being mindful of the available documents and make sure that they're current. Long-term care, I know, uses the SBAR to send when they're sending their residents into the hospital, using that communication handover and making sure that the transfer documents are completed, whether you're in acute care or long-term care. Just to summarize, prevention is the key. Early detection. We want to be able to prevent unnecessary transfers to long-term care from acute, unnecessary transfers to acute from long-term care and or readmissions. Ongoing assessments for those key features using the tools. We would be doing that assessment at rounds, shift report, hourly purposeful rounds, etc., using multiple interventions, non-pharmacological interventions being the priority. Pharmacological interventions are reserved for the severely distressed. And again, ongoing staff education to help with the early detection and prevention of a delirium from occurring. You may need to refer to geriatric services if behaviors are not resolved. And if you do, you can go into departments under long-term care, and you'll see here where it says Geriatric Services Resource Team. I'm just going to click on this hyperlink here. This is where you would want to go, where it says Geriatric Services Referral Form. You click that on, and then it provides you step-by-step instructions as to how you complete the form. I do want to remind you that it is a consult, and therefore you would need a physician's order to access our service. So at this time, I would like to thank you for your interest and encourage you to continue to be a voice for a very vulnerable geriatric population. Thank you.